Welcome everyone to the SCR Connections April webinar. Thank you so much for joining us. It is my pleasure to introduce today's guest speaker, Cathy Pepper. Catherine Pepper holds the rank of Tenured Associate Professor and serves as Coordinator of Library Field Services for the Medical Sciences Library at Texas A&M University. Based in Austin, Texas as Medical Librarian for the Round Rock campus of the Texas A&M Health Sciences Center, she also teaches public health informatics courses in A&M School of Public Health, as well as evidence-based medicine courses for A&M medical students. Cathy graduated from the CDC's Public Health Informatics Fellowship Program in 2008 and was recognized for outstanding service to the Informatics Office at the Coordinating Center for Infectious Diseases. She earned her master's degree in Library and Information Science at the University of Texas Austin School of Library and Information Sciences and her master's of Public Health and Health Informatics at the University of North Texas Health Science Center's School of Public Health. Cathy's research has focused on clinical decision support tools, the use of scholarly metrics to quantify faculty research impact, and the use of social network analysis for evaluation of public health information systems. Her current research, which she's going to tell us a little bit about today, is a qualitative study on best practices in teaching evidence-based practice. I'm going to go ahead and pass moderator control over to Cathy and let her get started with her presentation. Good morning, Cathy.
Good morning. Can you all hear me?
Yes, we hear you loud and clear. Thank you.
Awesome. Thank you. Well, I will now share my screen. And we'll get started. Well, hello, everyone. I'm really excited to be with you all today to share my research. And I think that some of the places I visited are on here now, some people that I visited. So I'm excited to welcome you, and I'm sure that if I make any mistakes, they will be sure to point those out. So I'm going to talk today about perspectives from the academic health sciences institutions that I visited over the course of last summer. And the project was funded by 2 grants. One was the Chronic Traveling Fellowship from the Medical Library Association, and the other was the Pilot Season Speedy Startup Grant from the South Central Academic Medical Libraries Consortium, or SCAML, which is the group of medical library directors in the 5-state SCC region, SCR region. So I was very grateful to get the support for my research, and I really am excited to show some of the results of that today. So I wanted to talk a little bit about why I went on this journey here, what the purpose and background is. Well, these are some of the aims that I had. I wanted to look at how evidence-based medicine is taught in various medical and health sciences schools. And by the way, one thing I learned, I'm going to go ahead and give you a result of what I learned. One thing was that health sciences disciplines other than medicine like to refer to it as evidence-based practice. So I use those terms interchangeably. They basically mean the same thing in terms of this study, but my focus really is on evidence-based medicine, and I'll tell you why in just a moment. I wanted to look at how all of these schools delivered the content of evidence-based medicine and how they assessed it. I wanted to especially look at challenges and how to overcome those challenges. I wanted to see what the influence of clinical decision support tools are that libraries license, and especially the influence of UpToDate. And I really wanted to see how much librarians are involved in teaching EVM and EVP in the curricula. So that was the purpose of the study. But why? Why did I do this study? Well, it really arose out of my own curiosity. Having taught evidence-based practice modules in the colleges of medicine and nursing and in the School of Public Health since I started at A&M in 2009, I had gone through a variety of different teaching modes and roles. Along with other instructors, I'd experienced varying levels of success with these different iterations. And I had become increasingly curious about just what is it that makes teaching this topic successful. How do we help our students get to the competency levels of evaluating and applying research and guidelines for diagnosis, treatment, and case management that patients need their doctors to be at? And I thought, if we're having issues here with teaching this topic, maybe other schools are also having issues, or maybe other schools have figured out what works and what doesn't work. So I wanted to see if others had figured out how to be successful at teaching evidence-based medicine, and if those insights and methods could be portable or adaptable to our own teaching. So it's really kind of personal. What is it that I need to be a successful teacher of EBM? So as is good evidence-based practice and being a librarian, of course my first step was to look into the literature. So in doing so, let's look at some definitions of terms. Along with evidence-based medicine, some other related topics have been emerging in the last few years that have sort of been co-located with EBM teaching and making their way into the curricula. However, today I'm going to focus just on evidence-based medicine, and I'm using this definition as the starting point. If you teach evidence-based medicine, or even if you don't, you may be aware of EBM, how EBM is thought of. It's generally thought of as a process that involves 5 steps: asking a clinical question, acquiring the best evidence, appraising the evidence, then applying the evidence, and assessing your performance, the 5 A's. And this is important because for medical residents, residencies expect their incoming interns to have these EBM competencies already under their belts. The core and trustable professional activities for entering residency for EBM describe the expected behaviors to follow this 5-step model. So here we see the key functions with related competencies. And then we see the expected behaviors for what is called an entrustable learner. So they're already supposed to be at this level when they go into residencies. But there are some issues in EBM competencies in practice that I found in the literature and in my own experience. Studies have said, or several studies have said, students don't apply EBM in practice. Also, about teaching methods, it's difficult to see which one is better than another. It was found that blended learning is more cost-effective than face-to-face. You can improve confidence with peer teaching, but not necessarily competencies with peer teaching. There are several different approaches. Integrate EBM with other courses, EBM faculty development, whole task exercises, and longitudinal integration of EBM over several years. But schools do need help in overcoming barriers related to EBM curriculum development and implementation, and there was a call for standardized competency frameworks in the literature. Librarians are involved in EBM instruction, and what I saw was mostly in the 1st and 3rd years. So these issues in my own experience fueled my study rationale. So we know that EBM is a common component of medical school curricula, and as we saw, it's a required competency for the residencies. But there's no standardized method of teaching EBM or of assessing students' competencies in EBM. And so we really don't know how well prepared our graduating medical students are to practice EBM when they go into residency. So these are my research questions. How well prepared are these students, and do they meet these EPAs? How is it taught and assessed in medical schools, and how effective are these teaching methods? There's always room for improvement. So how can we improve EBM teaching? So my goals are, or were, well, they still are, to develop a blueprint for EBM instruction that we can use in our own environments, can be adaptable for other settings. We want to ensure that, that the starting residency competencies are met. And we want to really raise for us librarians, we want to raise the awareness of librarians' roles in teaching EBM. Specific objectives really are looking at what is the structure and placement in the curriculum in other medical schools, what's the sweet spot. I want to identify common challenges in teaching and how to overcome those challenges, and how much librarians are involved, and also what is the value of teaching EVM. So how did I go about this? So this was what I wanted to do, is really talk to people. And so this really felt like a road trip. I wanted to talk to EVM instructors face-to-face, not over a phone, not with a survey, because it's only with face-to-face interviews that you can get a totality of the information that will really answer your core questions. And so this was a qualitative study. It's not a quantitative study, although I do have some numbers. The study design is a grounded theory, which means that I start in semi-structured interviews, which means that the framework evolves as you talk to more and more people, and especially in data analysis, it will open out and constrict as you look at the data. So I talked to people. I wanted to do semi-structured interviews, which means I started with a set of questions, and then I could just let the conversation lead us as it went. I also wanted to observe classes as I could, and I didn't pick any particular set of institutions. Just I wanted to see what was being done, no matter if there was a strong, what was perceived as a strong EVM program or none at all. So I wanted to get out of my region and see what's going on in other regions as well. So I think I covered 3 SCR regions. So I left home on July 29th to start my journey, and I did drive the entire way. I'll show you a summary in just a second, and these were the institutions that I visited. This was sort of in flux. Some of them had been set months before, and some of them came up as I talked to other people. So I visited, they were all in the Northwest and Midwest, and this was my route. So I started out from Austin, and you can see all of the different places that I went. It was a fun and challenging journey, for sure. But it was very, very informative. I got to talk to, you can see I talked to a great variety of different places. This is an example of my schedule at one of the sites, so my days were very full. This is a summary of the span of the data collection from July 29th to October 5th when I returned home to Austin. So I went to, yes, I did want to go up to Canada, but you'll see I just didn't have time. So 16 sites, I completed 90 interviews, and I'm counting everyone I talked to, even if some of them had a couple in a group, but I counted those as well because they contributed their own thoughts. It was about 45 minutes for an interview. I've got 400 pages of data, and I'm trying to distill it right now, so this is a challenge. All of these disciplines were represented. You can see medical schools medical schools and medical libraries were the most frequent, and I put a grand total of 11,000 miles on my car. So what did I do? So here were the questions that I asked. I had 9 questions. I wanted to see what your role in history. I asked what your role in history and teaching EVM was, and how you define EVM. When do you introduce EVM topics? What methods do you use, and how are students assessed? How well does EVM translate to medical practice, and how do these clinical decision support tools come in? How do clinical faculty receive faculty development in EVM? What barriers have you encountered, and how have you overcome them? I did ask about population health systems and big data, but I won't be talking about that today. Librarian involvement, and finally, what would you like to know about how other schools teach EVM? So as I go through, I'm going to kind of give you some of the themes that we've identified, and I'm going to give you some of the quotes that people had. Kind of get ready, because it's going to be a little bit intense until we get through the presentation of the data. I'm going to stop here and see if there are any questions right now.
Cathy, I think the only question that you have not answered so far, because you answered the candidate question, is this part of your dissertation?
No, I wish it were. I didn't have the foresight to do that. So, but it definitely could be. So, yeah, it is that. This, as J.R.R. Tolkien said, the Lord of the Rings. This tale grew in the telling. Okay, all right. So we'll move on to results, and fortunately, I was able to locate a qualitative data analyst, and we both looked at a sample of the transcripts until we reached the reached saturation, which is when we were kind of going realizing the same things over and over. And I'm going to show you that we did a second round coding of the barriers theme. So I'll talk about that in just a moment. So first of all, again, the types of schools that collected data from were medical, nursing, pharmacy, public health, and also just to let you know, I've divided them into faculty and librarians, 2 categories, and I had about equal numbers of interviews with each category. Now I realize that librarians are faculty, as is the case here at A&M. A lot of librarians have faculty status, but for purposes of this study, it was who you were employed by. If you were faculty employed by a health science school, I put you in the faculty category. If you were employed by the medical library, you went in the librarian category. So, so we had course thread directors, medical librarians, facilitators, and instructors. I did have 1 hospital that I talked to. So here were the main themes that my analyst and I came up with. First of all, what is happening now or in the past, or what do you want to happen in the future? What is the quality of the state of the EBM teaching there? What's the value? What's the importance, significance? What are barriers and strategies? And finally, recommendations. So these were the main categories that we coded their transcripts by. Along with that, we identified other elements such as course structure and content, concepts for retention, faculty expertise, assessment, librarian involvement, and I want to know. And you can see that a lot of these correspond to the questions. So I'm going to go through and show you how these relate to each other. So the first one was emphasis, amount of time spent, what is it, what is the current state? And so I'm going through and I'm presenting what people told me. One thing was terminology. Nurses tend to call it research or quality. And by the way, the little L or F out by the side indicates the category that responded to this or gave me this data point. So a librarian noticed that nurses tend to call it research or quality. EBM experience or credentials aren't standardized. There are a lot of volunteer faculty, untrained faculty with no formal EBM training, and preceptors sometimes model behavior and sometimes they don't. So that was on the faculty development or faculty expertise side. Also, a variety of teaching methods, orientations, active learning, TBLs, student-led learning. There were lectures. They were issuing lectures all over the place, a lot of variety in teaching. One place, I think this is a nursing faculty actually, taught the difference between research, evidence-based practice, and clinical practice. They also mentioned teaching the importance of journal credibility as a means of judging quality in research. Librarian as a resource to guide student in critical appraisal. Librarians in experiential learning, students hands-on with librarian as a guide mentor. The librarian provides feedback to students regarding research, and they taught levels of evidence. So these are just, again, not every place said these exact things. These were just data points that I gathered. For faculty, one person said the evaluation of the old curriculum informs the update of the new curriculum. The undergrads combined research and evidence-based medicine. This was at a nursing school, and the grads did a research course, and the EBP concepts were included in clinical courses. One medical school faculty said, we need a new way to teach, however. And indeed, what I found was all of the schools were in some kind of transition. They're redoing the curriculum, they're reforming the curriculum. There are various levels of readiness and incentives for teaching. So the timing, one thing that came out was, are you ready to change? The importance for thinking about readiness to learn. When does that happen in medical school, in nursing school, and pharmacy? The content is well received by students. It's a testament to the fact that content we need to rethink the content and how we do that for students. They're not ready for this content, but they need it now. So a lot of different areas and thoughts about this. There is not room in the curriculum, and we need to make room for uncertainty, is what these faculty were saying. Just as an example of the curriculum, as I go through, I'm going to show highlights from the quotes that I pulled out. Medical school faculty, one program had 4 facilitators who use EBM in practice, and that they use small groups, which is where the learning occurs, but the application is what's lacking, and that's why they bring in these practitioners who actually do it in practice. Here we first mention of assessments, which haven't been formalized. This person admitted we're not doing a great job of teaching, but they hope the team-based learning format would improve that. And the students didn't perform well on EBM, and one issue is they think they understand it, but they don't. I'm wondering if this is resonating with anyone who's listening now. I like this one from a physician's assistant faculty, and it points to the interprofessional aspect of finding out how other schools teach, not just other schools within your discipline, but schools in other disciplines. And I think that other schools have a lot to teach or can inform medical school evidence-based medicine teaching, and I'll talk a little bit more about that later. The next theme was the importance, significance, and value. So remember, that was, do we still need to teach EBM? And mostly I found EBM is still important, even though we have these tools. You can't replace asking the clinical question and doing the critical appraisal of the evidence. Residency director said that, yes, we do use evidence, but they're not so great at critical appraisal. And physicians need to know what they are looking for, so we really need an understanding of EBM for them. When I asked, what do you want to know, I got all kinds of answers. First of all, how do you teach EBM? What interactive methods are used? What are the perspectives of different disciplines? How do you integrate EBM over 4 years? How do they motivate students to apply EBM concepts? And just kind of the plea, are we all using different materials? Where does EBM fit into residencies? Are we having the same struggles? They want to see actual assignments from other institutions, and how can medical librarians become more involved in the curriculum? So this all pointed to the importance of EBM teaching in the various places that I visited. Medical faculty overwhelmingly thought, yes, it's still valuable to teach. And pharmacy faculty were saying, you're still seeing a lot of memorization. They're kind of going on from undergrad school. They are looking at knowledge-based and not critically thinking. So, and then here's the first mention of UpToDate. It's easy to use, but you're going to need to go into the primary literature at some point, and they're going to need to be able to do their own calculations. So that brings up the UpToDate factor. That's what I called it, the UpToDate factor. And I have a little bit about this. So there's a struggle with the right way to instruct them. A lot of students are going to use UpToDate as a single resource. But there is a need to show them how to get to the primary literature. One person said there's a difference between Dynamed and UpToDate. UpToDate is the author's perception of evidence. Dynamed is groups of content experts grading evidence. This is not always clear to students or to faculty. So one librarian started with point-of-care tools, and then she got into refining searches instead of the other way around, which is how I do it. So we start with where they are. They are starting with the apps and so forth. But one public health or residency faculty said, professors are there to help them, but it's not all in Hippocrates and UpToDate. And that expectation is something that needs to be changed. One faculty said, we just need to give up. There's no winning. There's the perception of students out there that they just need to look it up in an app. But we need to convey that data is not the same thing as information or knowledge. So that person said we try to hit it early and often. In our Intro to Public Health course, we cover how to do searches and how to ask the library for help. There were some people who disliked UpToDate and said it's still valuable to teach these skills, but UpToDate is a perfect example of why students and some residents don't think they need evidence-based medicine. Anytime I watch, UpToDate has a specific look, and the problem is they're not seeing it modeled by their faculty. But there's a time factor. There's really no time, they said, to do all the steps of UpToDate. Then some said it was useful but limited, and so there are some other comments on it that I will leave for you to look at because I don't want to spend a whole lot of time on this. So the basic thing is there's a shift toward medical faculty saying, okay, UpToDate is out there, but you need to also look at other resources. So this leads into barriers, and so let's see. So faculty and librarians had some different perspectives. They were frustrated that there's no standard definition of EBM. Actually, there is, but it's not consistent across institutions, and there's no standardized EBM curriculum. The first 2 years of medical school, you're teaching to the test, and there's no room in the curriculum. And there's underutilization of medical librarians. And one person mentioned about I added the category of culture and attitudes. There's a power imbalance among MDs and librarians. Organizational culture makes teaching EBM difficult, and that white coats need to teach EBM. Let's see. So there's a lot of memorization, students with information overload, student over-reliance on one or two sources, students question librarian expertise, timing of it. There can be a faculty-librarian disconnect, and students and clinicians do not understand the value. But they start to as they get into working with patients. So how do we overcome these barriers? Well, there are several strategies, and these concepts are about retention and reinforcement and repeating. When I asked which facet of EBM was the most important, a lot of them said, I think the first ranked was asking the clinical question, followed by critical appraisal, and then searching the literature. It's important to get champions and physicians and become familiar with what's being taught in the curricula, and promote librarian as an information specialist consultant. So the range of librarian involvement was extreme. It was from very heavily involved to no involvement. Some were quite involved, some weren't sure. Notice that one nursing faculty said, we didn't know how to operationalize them. And I said, well, have you asked? And she said, no, I haven't thought to ask them. That's a good idea. So, some said they should be involved in everything, would love if they would go on rounds with us. So again, a lot of range of involvement here, and it looks like some of them don't really know what skills are. However, others were very appreciative and appreciated the effort of going through the curriculum and matching instruction to what was being taught. So again, it's all about the relationship, and there were some critical comments here. There's a disconnect when people transitioned into and out of jobs, and so the relationship was high importance. So let's see, I'm going to go on to recommendations and talk about what some of the things that faculty and librarians recommended. So one recommendation was to form EBM professional organizations and write EBM guidelines, interprofessional collaboration, promote librarian as resource, and increase librarian involvement from small to greater involvement as the years go on. There may be an argument for dedicated EBM courses and embed EBM throughout. Actually, I got this from several people. Differentiate levels of instruction. Not every student needs to know the full depth and scope of EBM. Some are doers. They're the ones who will do the research versus consumers. They're the users. One thing was cultivate a spirit of inquiry and develop the content emotionally compelling way. Tie it to real patients. The biggest hurdle that they face is that they want to be certain. They want to go at a superficial level instead of digging down and really thinking about it. So I went into more of a thematic breakdown with the barriers, but I am going to leave that for you to look at in the slides that you'll be getting, because I think this kind of breaks down the problems that we need to attack, and we identified several categories of barriers. So what they said did not work was surveys of how confident students feel about it, because those levels and their actual competence are two different things. Not to keep away from teaching statistics heavily. Online modules starting out does not work, and one professor said, I used to stand in front of the class and ask them questions, and that did not work either. So what may work is the scheme for the new medical school at the Idaho College of Osteopathic Medicine. I was very impressed with these people. They just started their medical school this past fall with a systems-based approach to teaching. And they have this philosophy that they want to instill lifelong learning, and they know that contextualizing is the best way to learn. So they have an EBM course that's incorporated into really all 4 years. They are not spoon-feeding the information. It's about searching for answers on your own. And they do not purchase UpToDate. And they are emphasizing faculty's modeling behavior. They realize that clinicians need some training in EBM, and they are building this into the faculty evaluation, which I thought was very interesting. They did hire a librarian on faculty, and she is highly involved in framing the EBM course. So with all that, and that is only a tiny fraction of all the information that I gathered, and so I just wanted to share. Yes, that was Molly. That was Molly. It would be great to go back and see how things are going, Molly. So yeah, that was really exciting. So so some of my perceptions. What did I think about this? Well, to me, I saw that assessment was the most common area of frustration and avoidance. There are existing objective tests, but they're rarely used. At least they weren't in the institutions I visited. So clinical questions are going unanswered, and the barriers are access to medical information and the skills in searching information resources, which seem to be taken for granted by a lot of the faculty and by the students. So there are a lot of variations in views on UpToDate. It appears that people think that UpToDate may interfere with efforts to teach critical thinking, and there is that side by side with the perception that UpToDate equals evidence-based medicine. And then there's the realization that occurs in residency, that other sources and EBM skills are necessary after all. But oh, I forgot what I was taught in the first year of medical school. So faculty should model appropriate use of UpToDate and demonstrate different purposes of all tools and resources. It's there, it's going to be there. One thing I'm wondering, is there a gap? We have the standard definition for EBM, but here's the definition that a medical faculty member used: using the best evidence to provide the outcome for the patient. So what is best? how do we tell them what is best? How do they understand what is best evidence? And what's implied is it the treating physician's expertise, or is it the UpToDate author's expertise? And then what about patient values and preferences? And all of these actually go into the clinical decision, because we know that those are the three legs of evidence-based medicine. So do we emphasize, my question is, do we emphasize the evidence element too much? Is this one reason that students find it dry and don't use it in practice? So I did find that EBM is a hot topic. It can be tricky. There are tricky political environments. There's tricky funding. Some schools had experienced a recent decline in funding, and that made it very difficult to do EBM teaching. Make it real, make it relevant. There were some geographical barriers as well. And really, everyone is really not, we really don't know when to time the EBM education. I wanted to call your attention to a fantastic article by Swanberg et al. And this actually this actually validated what I found, and I didn't see this article until after I completed my research. But this is, they did a systematic review and came up with 27 articles and found that there was little change in competencies from teaching method to teaching method. And so they recommended that we do multi-site trials to look at how to measure these competencies and get standardized outcomes. So this is, I recommend this article highly. It's really good. So do we need to change EBM? The whole Medline search, bedside, then do search, come back, nobody does that anymore, said one medical faculty. So really, let's move this into other roles like quality improvement. And they bring the student to see the patient and into the OR, but their students don't come to the QI meeting, so they miss out on this. And I think this speaks to the systems thinking, the health system science aspect that some schools were starting to do, but most were not. So let's do a study check, the research questions. How well prepared? Some are, some aren't. Mostly anecdotal assessment, and I noticed there was not much assessment of searching skills. How is the soft topic taught? Threaded, case-based, student-led, integrated, and some are in the clinical years and some are not. So we don't really know how effective these teaching methods are, as Swanberg found. So, however, I have covered so far these objectives that I mentioned at the beginning. So this is my research focus now, and that is ongoing now. So what I'm moving toward is a blueprint. What I found is that faculty are passionate. Faculty and librarians are passionate about improving EBM learning. As I said, it's a hot topic. Medical schools can improve EBM learning by talking with other health sciences schools. Need to bring different perspectives together. And there's objective assessments of all 5 steps. We need objective assessments for every single step. And so really we need to retitle this. This is toward or in search of best practices, because we don't have a consensus right now. We're not there yet. And so what I'm calling for is a consensus. I would like to have a repository and forum where people can share their materials, their experiences, their questions. An interdisciplinary task force that is both intra-institutional and inter-institutional, where no one discipline is the quote-unquote leader, because let's face it, most of them, especially medical schools, tend to work in silos, and we need to share our experiences and outcomes and really focus on reliable assessment. So some things to think about, that a lot of people were just very excited to talk. So if librarians want to go out and talk to their faculty, I would say that is a good opportunity to open up some discussions. But there are a lot of assumptions that clinical faculty, for example, know EBM and that they incorporate it into their teaching. We assume that graduating MDs possess EBM competencies, but what I found is that they're really not over on that right side. They're somewhere in the middle here. So how can we move them from these middle behaviors, these developing behaviors, over to the expected behaviors for residencies? There's a wide variety in perceptions of role of librarians in teaching EBM. Some faculty said librarians are only, quote, good for teaching the searching step, and some librarians also said that same thing. So for teaching, I asked, quite a few of them said, no, we don't let librarians teach the PICO or the clinical question, and we don't let them teach critical appraisal. So that was very interesting, and no consensus on assessment. So what's next? So as usual with an exploratory study like this, it just opens up and leads to more questions. So my next research focus is to actually look at the accreditation criteria, the competencies that LCME requires and that ACGME requires. How are they assured that students are actually meeting these competencies since they are not on the boards, they're not in step 1 and just a little bit in step 2, and how do residencies deal with it, and what are these assumptions? So I'm going to look at this, I want to do a gap analysis on this area here. And the results, I'm hoping, will be able to come up with a model or a framework for teaching EBM, and to further that, and to help get all of our perspectives together, I'm going to try to start a repository and a forum, and a EBM teaching community of practice, or community of excellence, really. So that's my research. I would be delighted to take any questions now. I do have had a lot of questions about, well, what did you do on the weekends? So just sort of showing you a little bit about what happened on the way. Of course, the weekends were mine. I had 9 weekends to take a break from the study. By the way, I was still doing my regular job while I did this. So I taught a couple of classes online while I was gone. I answered emails, and I kept up with what was going back home. So anyway, but on the way I saw some amazing sites. Here's Palo Duro Canyon. Here are my wonderful colleagues at University of Colorado, Melissa DeSantis and Vesper and Lisa Traditti, and from there I saw the Colorado Rockies. Here are the Salt Flats. Melanie told me about these, and it was just fascinating. I went hiking in the Sierra Mountains. Here's Mono Lake, and then here are Heidi Heilman and Nicole Captorest at Stanford, and they took me to see the Gates of Hell at Rodin's Gates of Hell. That was a lot of fun, and it also happened to be the eclipse, and the entire world was going to the West Coast, but I was able to stay with my cousin in Portland, and I saw the total eclipse there, and then just had some more amazing experiences as I went through and saw some wonderful sights of our country. I really encouraged a driving trip. By late September, I was getting a little homesick, and the leaves are starting to turn, but I still had some places to go. And one of the most amazing things I saw was the Dignity Sacagawea sculpture overlooking the Missouri River. And this was, I was driving along and I saw this and I thought, what in the world is that? And it was truly amazing, a 50-foot high statue honoring the Dakota and Lakota peoples. So with that, I would like to very much thank Esther Kerrigan, my director, for letting me go on this adventure for 2 months, and Luann Cole, who is the qualitative data analyst that I used, and Andy Massica, Dr. Massica, who is teaching EBM in the intersession for our third-year students right now. And again, thank you to MLA and SCAML for providing the means to go on this trip. And here are just a few of the people I wanted to recognize and thank. They were just also welcoming, and I just really appreciate being allowed to visit you all and talk with you. So, so right now I will take your questions. So Sarah, if you want to shoot them to me now.
Yes, we've had quite a few of great questions come in the chat, both earlier in the presentation and here at the end. So I'll go try to make sure I field all the ones that we did see. One of the early questions, Cathy, was about how did you determine your budget for this whole process?
Oh, good question. Yeah. Yes, so I wanted to make sure that I had a large enough sample that would lend to validity of the data. So I knew that I wanted to visit multiple institutions, and so I just figured I looked at the number of institutions that I could cover within 2 months. I wanted to really take a good amount of time to do this. And so I just figured, you know, X amount of dollars for hotel rooms, for X amount for gasoline, and so forth. But I will say that I funded a bit of it myself. All of the hotels on the weekends, of course, I funded myself. Of course, I was able to spend some time with, some of that time with friends, so that helped out. But if you want more detail on how I figured out the budget, I'm happy to share that with you, because I did up a spreadsheet and I looked at the maps and the institutions and so forth. So yeah, I'd be happy to share that with you if you want to shoot me an email.
Great, thank you, Cathy. Next question was, how did you determine your choice of locations? Were you considering whether it was a lesser known school or maybe only regional school? And also, did you think about looking at like the Hispanic serving institutions, things like that?
Yeah, so I knew I wanted to visit schools in other RML areas. So I was able to go to I think 4 RML areas, and I wanted to look at schools of varying sizes and varying levels of involvement with EBM. There was one school that really didn't teach EBM much at all, or one library, I should say, and that was fine. I wanted to gather everything and was not making a judgment on whether it was strong or weak or whatever. I just wanted to see what's going on out there. I sent out invitations to folks. A couple of folks reached out on my behalf, and I secured some interviews and sites that way. So it was sort of a variety of methods to identify the sites.
Great. Then we have a couple of questions about the apps and the UpToDate question. One person is wondering, can you say more about how you start with the apps and move into lit searching from there? And the other question was about why UpToDate versus Clinical Key.
Okay, I might not have been clear about that. What they did was they started from not just UpToDate, but also Dynamed, Clinical Key, and other things that were kind of obvious for the students. Let's face it, the students are all app-oriented. They want stuff that's on their devices. And so if you can start from that, the theory was if you start from what they see already on their phones, then you can move into the more complex literature, primary literature. So, for example, UpToDate, Dynamed, all of these places do refer to the primary literature. So that is an entry point into the literature. So it goes from app to the reference to the primary literature, and from there you can start teaching the PubMed and search strategies from that way. So instead of starting from PubMed, which is sometimes intimidating and it's not familiar to them, start with something that goes with the technology that they're familiar with. I'm not sure if that answers your question, and I might have forgotten the second part of it.
That's fine. So the second part was just about the UpToDate versus other things like Clinical Key. And the secondary question that just came in is, did everywhere that you visited have UpToDate?
No, they did not. Several places said we refuse to license it. And I will say A&M, we at MSL refused to license UpToDate. There were other places, though, that felt like they had to because the clamor would be too great if they did not.
Right. All right, and then the next question, which I know will be a difficult one. There's been several different questions about a similar topic about collaboration between librarians and faculty.
Yeah.
So has the faculty you've interviewed seemed open to collaborating? What are your suggestions for librarians? What's the best way of figuring out what can librarians do and not do, and how can we complement what the clinicians are teaching? just more asking about that collaboration aspect.
Right, yeah. Some faculty were very, very open to having librarians collaborate with them. Some of them pigeonholed librarians, and they said, well, we'll send them over and to the library, and so there were all kinds of variations. So to those of you, or for those of you who have high faculty collaboration already, kudos. And that's something that I would like to put into the repository, is share your stories about how you got to that level, because it's although there are some common things we can all probably implement, there are other things that are unique to your own institution, such as the funding cuts. If you don't have the funding, if you don't have the staff, the capacity, the workforce capacity, it's very, very difficult. So that's sort of a stopper right there. Others mentioned librarians being on curriculum committee, and I was surprised that several of the sites I visited, the librarians were not on curriculum committee or engaged in the faculty meetings about EBM. So that was one suggestion. Another thing is, I also heard about the physician champion. So working with the physician faculty to show what it is that you can teach. Just as an aside, and how I got to Dr. Massico, who teaches our EBM intercession course, which is a new way of teaching it, by the way. We taught it for the first time last year this way. Actually, I was a facilitator, but I created a hedge not a hedge, but a search strategy to append to subject terms in PubMed to narrow it down to systematic reviews and clinical trials and so forth. Well, you would have thought this was hanging the moon. I mean, it's so simple to us, but when they saw that PowerPoint that I sent out, they said, thank you, this is what we need. So it was both, they don't know what they don't know, right? And so it's really availing yourself of the opportunity to get in there and say, hey, here's a way to make it easy on yourself. And we actually know how to do this. So I think just informal conversations, as I said, as I noticed before, it's the relationship. It's building those relationships, and don't be afraid, because they are the ones I talked to were very welcoming and very open. Now, I mean, I did come across some who were sort of closed and already had librarians in a category that did not involve collaborating. So I think that goes back to basic relationship building and just being in the same space with them. So, you know, getting out of the library and into their space, walking the halls and so forth.
Great. Thank you so much, Cathy. I'm sure this will be an ongoing conversation and experience as we figure out how to navigate this. We've had some really, really great questions, but unfortunately we do have to start wrapping it up for today, as we have a few final housekeeping things. But one last question for you, Cathy. I've had several people say that they would love to see this published. Do you have any plans to publish some of this research that you've done?
Thank you. That's so gratifying. Yes, I do have plans to publish, and we'll be writing this up. I mean, we're making a third pass. We're just now starting a third pass through the data, and getting just this sample of 16. Thank you, Erin. I appreciate that. Getting just a sample of 16 and analyzing that has taken hours and hours and hours on the part of both Luann Cole and myself. So. But every single interview, although there were common themes, and we had reached saturation, which means we kept running across the same themes over and over, but every interview had a gem or a nugget, something unique. And so those are the things I want to pull out. I'll be pulling those out for the MLA presentation on Monday at MLA, I think it's at 1 o'clock. And so yeah, I mean, this is an ongoing thing, just analyzing these 400 plus pages of data. And so yes, that does need to be published. So probably, hopefully at least a couple of papers will come out on this.
All right, great. And several of our commenters have also asked that you publish outside just the library literature. It'd be great to spread this. Yes, medical educators as well.
Thank you. I appreciate that very much. Yes, I will be targeting medical education journals and other health sciences journals as well.
Wonderful. Well, thank you for a fabulous presentation today, Cathy. We're going to wrap up our Q&A. I'm going to stop the recording. We do have a few final housekeeping, so if everyone else would stick around, but thank you so much, Cathy.
Thank you. And if you could send me the chat transcript.
Yes, absolutely. I will do that. And Cathy's email is there on the screen. If anyone wants to follow up with her, I'm sure she'd be happy to take questions via email.
Absolutely. I know this was really, really fast, and I kind of sped through some stuff. So I'm glad you'll have the slides, and I'm happy to take any questions by email. And thank you all again for letting me join you today.
All right. Thank you, Cathy. I'm going to go ahead now and stop the recording, and then we'll do our final housekeeping.
Thank you all. Bye-bye.